Hello cruel world, my name is Dr. Shaham Das. I'm a consultant forensic psychiatrist and I'm here to answer your questions from the internet. Let's get started. Question number 1, does schizophrenia come and go? Well, psychosis, which is like a temporary state of being out of touch in reality, that can come and go. So around a third of people who suffer from a psychotic episode will get well and never experience it again. About a third will eventually get over that one episode, although it might take a while and it might fluctuate. And about a third will have a relapsing and remitting illness for life, a chronic illness. A relapse is when you get worse and remission is when you get better. Schizophrenia falls into that last category. So just like having one seizure isn't epilepsy, but having several seizures or a tendency to have seizures is epilepsy, in that same way, a tendency of recurrent psychosis is schizophrenia. So by definition, schizophrenia is relapsing and remitting. Schizophrenia itself tends to fluctuate just naturally with the course of the disease, and there's also factors. So for example, taking antipsychotic medication is likely to lead to improvement. And also some illicit drugs, especially cannabis, amphetamines, is likely to cause relapse, as is a stressful life event. Question number 2, how to treat involuntary patients. So my interpretation of that is like, how do you work with involuntary patients? So in the UK, involuntary patients means that they're detained under the Mental Health Act in hospital, which is the majority of patients, especially nowadays. So I think the best way is to work as far as is possible, collaboratively, and inform the patient. So not so long ago, maybe 30, 40 years ago, the psychiatrists would just make whatever decisions they want and they would just kind of burden the patient with their choice and the patient had almost no say. But things have moved on. Nowadays, a good psychiatrist will discuss options. So for example, say they think the patient needs an antidepressant. A good psychiatrist will give the patient lots of different options, explain the doses, explain the side effects, and help the patient choose. Or for example, if they think the patient needs therapy, they will outline all the options and explain the differences between them. Maybe even invite a ward psychologist to speak to the patient as well. However, having said all that, sometimes, especially in my line of work, so I work with mentally disordered offenders, patients don't have insight. So for example, there might be somebody who's psychotic, who's really paranoid, hearing voices, having delusions, but they don't believe that they're mentally unwell. They think those experiences are real, so they refuse medication. And in those cases, as a last resort, we have to utilise our powers under the Mental Health Act, which might mean medicating them against their will, for example, giving them a depot medication. Question number 3, can having psychotic depression affect your personality after remission? So just very briefly, there's different levels of depression, mild, moderate and severe. Psychotic depression is always severe, so it's when the depression is so intense that the patient has psychotic symptoms like hearing voices or specific types of delusions. So to answer the question, if you're in full remission, so you've fully gotten over your depression, then no, it won't affect your personality. However, if you're not fully clear of symptoms, you might still have like negative cognitions. So you might feel guilt, you might feel like pessimism about the future, you might feel paranoia that people don't like you or want to hurt you or don't want to care for you. So those aren't features of your personality. It's not your personality that's changed, it's just kind of a residual symptomatology of the depression that you previously had. And another kind of mechanism is that often with depression you get a massive lack of energy, so you just kind of lose the volition or the will to do much. If that remains, then that might appear to be affecting your personality, although technically, as I said, it's not your personality, it's just the remnants of depression. Question number 4, as a psychiatrist, what was your most challenging case? This is quite hard to answer because there are so many different aspects of cases that they can be challenging in different ways. So to be specific, in terms, so I should say that I'm a forensic psychiatrist, so I work with offenders. In terms of the most kind of horrific offence, not so long ago I assessed a woman who was completely psychotic after childbirth, known as puerperal psychosis, and this is quite disturbing, but she beheaded and killed her own baby. So obviously that was emotionally quite tough to deal with. Diagnostically, I remember a woman who I assessed in prison. She was from China. There was absolutely no background information on her whatsoever. There was barely any record that she existed. Her index offence was very bizarre. It was like stalking her doctor, and she was a bit violent towards this doctor as well. But the reason it was difficult was because she absolutely refused to engage with anybody from the prison team, the mental health team, including myself. So it's just impossible to kind of elicit any symptoms to really know what was going on. I strongly suspected she was psychotic because she just did nothing all day in her cell. She hid away, she would eat her food, not speak to anybody at all. But I couldn't really prove it because I couldn't tease out symptomatology. And the hardest bit was actually trying to convince a medium secure unit hospital to accept her, to psychiatrically assess her, because they wanted proof that she was unwell, because they have long waiting lists and there's always a pressure on beds. So it took a lot of effort, a lot of re-referring, a lot of speaking to lots of doctors before eventually I convinced them to take her. It took me, I think, 3 or 4 months just to do that. And then on a day-to-day basis, in terms of patient management, I remember when I was a consultant on a secure unit, I had this one particular man who had an intractable bipolar affective disorder. So it means that he just wouldn't get better despite all the medications, mood stabilizers, antipsychotics that we gave him. And this man was actually very hostile and aggressive, and he could be quite nasty. He was racist, he was just very insulting, he would attack nurses. His violence wasn't really that intense, especially compared to other incidents that we would expect on our wards, but it was just relentless. It was like every single day we had to face this vitriol and bile, and me especially, because I was his consultant and I was the one sort of medicating him. So yeah, he was the hardest to deal with. And also, and in terms of another kind of emotional pull, when I was a junior doctor, I had a patient who committed suicide on the ward whilst I was on call. So I was literally there at the scene, at the aftermath, and had to speak to her husband to let him know what had happened with his wife. So that was obviously emotionally very draining. That's it for today. Please subscribe to my channel. It's called A Psych for Sore Minds. Check out some of the other videos. I cover a whole range of topics related to mental health, some to do with violence and offending, some high profile cases, for example, and some to do with more kind of common, familiar mental illnesses. And my USP, I think, is that I discuss my real life cases in some of my videos, anonymizing the patient, of course. So hope to catch you on that channel. Until next time, stay euthymic, take care of yourselves.